Dr. Nicole Orzechowski. Clinical interests are in the evaluation and management of patients with vasculitis, inflammatory arthritis, and scleroderma, and the use of musculoskeletal ultrasound for diagnosis and response to treatment in rheumatologic conditions. She strives to provide exceptional individualized care to each of her patients, and her academic interests are in medical education, where she has mentored medical students, residents, and rheumatology fellows, and is involved in educational committees at the American College of Rheumatology. She has experience in enhancing care for rheumatology patients through novel care delivery models. Also up here joining us is Dr. Eve Wu. Dr. Wu received her medical degree from Mercer University School of Medicine in Macon, Georgia, followed by a general pediatrics residency at Vanderbilt University Medical Center in Nashville, Tennessee, and a dual fellowship in allergy and immunology and pediatric rheumatology at Duke University Medical Center. She also has a Master of Science in Clinical Research degree through the Department of Epidemiology and UNC Gilling School of Global Public Health. And Dr. Wu joined the Department of Pediatrics at the University of North Carolina in 2013. Thank you for being up here, helping us with all of this. I have a few starter questions while those of you are thinking about it, but honestly, just think about living with vasculitis and how can you have quality of life. I always have questions, so I know you must have. And I just want to say, seeing all of you in the room, I think when I was first diagnosed in 2008, I didn't know anybody that had vasculitis. So it's good to see that we have this many people that can ask the questions and that we are all living with vasculitis. I'm going to start with some questions that have been sent in. I might start with it if I have my list.
But look, we have them already.
Okay,
Just in case no one had questions.
good news. My list is over there on the table. So, okay, so.
I don't think they weren't sent in. They were just me.
Okay.
Based on questions we get asked a
Yeah,
lot.
Jennifer listens to all of the patient questions all of the time. What are you? One of the questions. Anybody want to start?
Leap a lot. No. It's a really horrible symptom, and it just lasts forever and ever and ever. I think probably a couple things that you can do for yourself that will probably help. One thing that I am notorious for not doing, which is being active. I hate the word exercise because people get ideas in their heads about what that means. Just walking, just something to get your body moving. It really does kind of help combat that. And I cannot speak enough to the importance of eating a healthy diet. We just do terrible things to ourselves by the garbage that we put in there. So, so I think those are probably two of the biggest things that you could do to help yourself.
Okay, great. Do you want to add something?
I'll add, I think, yes, exercise, diet, I think routine could be really helpful and, trying to be social, engage with others. I think everyone deserves to find their Thelma or Louise, or maybe someone who doesn't have vasculitis. I think those can be helpful as well and energizing.
Thank you. I'm going to move on to the next one. I did want to say though, we're all going to eat lunch together and all of us have different, things that we've done to deal with this disease. So ask fellow patients, find your Thelma and Louise as suggested. Is it common not to be able to stop taking steroids? This person was diagnosed with GPA in 2018. All right, Dr. Darabol, it's you.
So I would say it's not uncommon that we see patients who need to stay on steroids, and some of that has been a little bit of, I think, practice over the years. In that, I think the recommendations from a lot of the clinical trials and the way they were developed were to keep patients on steroids. Granted, it was low dose steroids, like 5 milligrams of prednisone, beyond that 6-month period, and for perpetuity. I can't speak to that. But what we're really trying to do now is to look at those patients and re-examine them and try to see if we can get people off steroids very gradually. There are the occasional patient, I think it's really hard to do that just because they do have some persistent symptoms. And when you've been on steroids for a long time and then you come off, you feel awful. So then it's hard to tell if that's a disease flare or if that's just because you don't have the steroids that are there to help you restore back or whatever else they also do.
I completely agree with that. And I also want to say, we focused today primarily on vasculitis, but there are other types of vasculitis. Obviously, lots of other types, and I don't know if there are others in the room that are suffering with other types of vasculitis, but there are some patients that do stay on low doses of prednisone for very long periods of time with other types. And we don't necessarily like that to happen for our patients. We always want them to come off completely, but there are some instances where for instance, patients with, say, giant cell arteritis or temporal arteritis will end up staying on very low doses for long.
Okay, thanks. This is another medicine question, maybe it relates a little. Doctors have told me I'll be on Ritux for the rest of my life, although I was previously off of it for 6 years. Why the change after my recent flare? Dr. Falk wants to come here.
I could hear it pushing from there. Into that question.
Oh, Dr. Brant.
A lot of people will answer that one.
I do not know what he said. I would say that would be highly unusual that somebody would be on Ritux for the rest of their life. I think those days of keeping people on maintenance immunosuppression forever and ever and ever, as long as they live, mostly bygone, except for these exceptions like Nicole was talking about. So I don't know why they would have said that, but I can't. Great reason.
Okay. How can you determine if pain is associated with vasculitis or being active as a child with vasculitis?
Ask me that again.
Sorry, I'm like.
How can you determine if pain is associated with vasculitis or just being active in a child?
Yeah, I think that's an excellent question, and I imagine those are themes that are also relevant to adults too, right? Having pain, and how can you distinguish whether it's due to your vasculitis or not? And I think that's where working with your providers. I think some of the other things that have been already discussed, maybe sort of previewed by Dr. Falk, but learning about finding a marker that will let us know that your disease is in remission, right? That for all intents and purposes, it appears your vasculitis, whether it be ANCA or other, seems to be quiet, that you can come off therapy. And so maybe that the pain that you're experiencing, while still as important to think about and manage, may not necessarily be related to your vasculitis.
Thank you. Great answer. Anybody else? Okay. This one's interesting. Speaking of other forms of vasculitis, I have Behçet's disease, and most of my doctors only Behçet's patients. And I have never met someone with my disease. How do I navigate new symptoms when most of my doctors are unaware as to whether my new symptom complaint is even Behçet's disease related? It feels like it takes a long time to get relief. Help. That's what it says.
I'm sorry to hear that. I'm hoping you have a rheumatologist taking care of you, because that should be your go-to person if you have new symptoms and you're concerned about those symptoms being related to your Behçet's. Behçet's is rare and can have many, many different symptoms and really can mimic a lot of things. And so your rheumatologist should be your go-to person. That's my answer for you.
Anybody else? Okay, thank you. How have you started integrating avacopan into treatment regimens? That's interesting because there are a lot of people that don't know.
Me.
Yeah.
I want to answer that. Let me give a little background. I was one of the people on the Arthritis and Advisory Committee during the FDA meeting deciding whether to approve this or not. And every single person on that committee, every single person without exception, had misgivings. Interestingly, each person had their own misgivings. It wasn't all the same. So it was kind of, you end up having to answer a series of questions, yes or no, yes or no. And literally, it was 50-50 for every single question. But then in clinic, I had patients where I had nothing else. I will give you one example. Patient whose kidney function was declining. I treated her with Ritux. She had previously gotten cyclophosphamide. I treated her even with some more steroids and more Ritux. Just her kidney disease would not go into remission. I was like, I got nothing else. Let's try it. Her GFR is terrible. Her kidney function is terrible. However, it has not declined any further since I put her on that. So I think I call that a win. I just this past week had a very elderly woman come in, very severe disease, both pulmonary hemorrhage, but also really severe kidney injury, creatinine about 6. A long story short, because it was kind of complicated. On Friday, we ended up doing a couple of hours of dialysis, but we were also able, through a special permission, the dialysis was Thursday, not Friday, able to get her Avacopan approved just for this one patient. It's not on our formulary. So we got that started the next day. And by the beginning of the following week, she was already remarkably better. The kidney function was, it's not fantastic now. Let's not get carried away. But when you go from a creatinine of 6 to a creatinine of 3.5, and actually now it is down to about 3. So she continues to improve. So I do think it offers some benefit that we haven't seen with other things. And it seems, again, I only have a handful of patients on it because I sort of reserve it for the people who are more problematic, but some of the responses are pretty dramatic. And then I have a couple of people on it because one example is a patient who's on dialysis, awaiting a transplant. But if you give them rituximab, it messes up their transplant labs, as I discovered the hard way. And so he's been in remission, but I put him on it just to hopefully keep that remission. So if a kidney comes up, he's not unable to get it because, that would be about the time he would flare. So I think it's got a lot of promise. We don't know yet about other organ systems specifically. I did ask that question. I've talked to the medical liaison, long conversation with him, but there's a phase 4 study starting up. That's going to look at the drug over 5 years. The first study was over 1 year, but also looking at things like pulmonary disease and other organ systems. They, I think, did a little retrospective of the original advocate study. There were a handful of people with pulmonary disease they looked at. Seems like there's a signal there that it may offer benefit, but it was not enough people to tell for sure. So. Yes.
That's right. So go to the breakout sessions later. Another Avacopan question. I'm on dialysis and low dose 5 milligrams prednisone, and it keeps me stable. Any use of Avacopan for me? So they're on dialysis and low dose prednisone and wants to know if Avacopan should be.
I think the honest answer is we probably don't know. Again, the original trial was looking specifically at kidney involvement. Well, you're already on dialysis, what are you going to do there? I'd be curious. Don't yell it out now. What other systems were involved that require you to still be on prednisone would be one question. But I think the answer is we don't know.
Okay, and this one interesting question about moving to no immunosuppressive. I just did want to say that, like in 2013, Dr. Falk said to me, you came in the office and he said, you're an L-trot. An L-trot. You probably remember that. Since I was family. Long-term off remission, long-term off treatment, or whatever. Anyway, that's.
Long-term remission off therapy, L-trot.
I think I could spell that. So for a patient recently moving to no immunosuppressive therapy, what should be monitored and how often?
Yeah, so that's a great question. I was actually going to probably prod Dr. Falk a little bit and ask him what he calls someone who is in long-term remission on therapy.
Yeah.
But that's probably gonna get me fired, so I'm gonna retract that question.
On therapy, doctor.
Same letters. So, I think part of this is I think, a lot of the patients we've taken off treatment have been, what we describe as shared decision-making between the patient and the doctor, because over the years that patients had the disease, they become pretty attuned to what their disease is like. And Dr. Falk taught me this as a fellow, is that if the patient tells you they're flaring, listen to them, So I think being very attuned to your own symptoms is really important. And just being, I think, willing to come and be evaluated. I think a lot of, we see patients sort of go in one direction or the other where they minimize their symptoms because they don't want to flare and don't want to admit they're having a flare. And then we see patients who are so anxious about having a flare that everything that happens to them think they could be a flare. And I think as you and your doctor learn about your disease, I think you get a sense of what that's like. But usually when we take patients off treatment, we see them pretty frequently afterwards, at least every 2 months, and sometimes even more frequently in those first several months. And as we all become more comfortable that it looks like they've reached a point of remission, we start to spread that out. But generally, we're following people really closely, and that takes capacity, unfortunately. So that means having availability to get patients on and being able to get back and forth to your doctor. And sometimes it's a well child visit where everybody's feeling great and looks fine, but we do subtle things like looking up some of the blood work that we think might be helpful, but don't really have a great biomarker yet. But we look at the urine under the microscope on a religious basis, and so trying to find those little subtle symptoms that tell us the disease is coming back is important. It's really just frequency of seeing your doctor.
And one thing, and I actually learned this from Dr. Falk also, is especially because where I am is very rural. So I have patients who make a 3-hour each way trip just to come to clinic. And so it's not convenient for them to come let me look at their urine every couple of weeks. So I have them do dipsticks at home, be on the stick. It's great, a lot of fun. If you're colorblind, it's going to be problematic, so get somebody else to look at it for you. But that's a great way to catch things before you even feel anything. You had no blood, you had no protein. We know that because we looked at it in clinic. And I'll say, if you notice blood, you notice protein, you call me. You don't wait, you just go ahead and call me and we'll figure it out from there. But as Vimal pointed out, I think it's very hard in the early phases of disease because it's new for you too. So you have no idea what are you looking for? So what I'll usually tell people early on is you just call me. If you don't feel right, you just call me. It's not your job to figure that out. It's our job to figure it out together.
Okay, I've been asked to have you kiss the microphone as you're talking, so that they can hear you. Maybe not.
Not me.
Is it common to have cold and sinus issues frequently, even when in remission? Cold and sinus issues.
Sinus issues, yes.
It's, yes.
I think the sinus issues are permanent personally.
So unfortunately, Dr. Senior is not here yet, I don't think, but he's our ENT doctor. He'll be here later today. I think I'm as close as I can get to this microphone without
That's
actually.
very good.
But I also have a tendency to not be audible, so apologies for that. But no, this goes back to what we have talked about in terms of the active disease versus damage from the disease. And while we can get people, we hope to get people to that restoration of health where their immune system is no longer causing damage. The damage that's already happened is just hard to manage sometimes. And I think sinus disease is probably one of the most frustrating things for both, I think, patients and for us to figure out what to do for, because it is so hard to tell if it's active disease or a flare. And we routinely send our folks to our ENT doctors who almost always put a camera up into their sinuses and look. And unfortunately, that's right now the best way we have of gauging activity versus infection or some other thing that's going on.
Yes, the Dr. Senior is speaking in one of the breakout sessions at 1:45. So that would be a great place to go. And I've also seen Dr. Senior. I've seen all of you. This person says, I'm stuck in a cycle of doctor determining of whether disease is in a flare-up or just active disease. Was recently switched from rituximab to IVIG Privigen, to get my disease maintained, and how will Privigen help? Or is there a different section today that they should ask the question in?
I'm gonna talk only because I'm uncomfortable with the silence. I guess without knowing more details. We have used IVIG or it was basically taking antibodies pooled from lots of different donors and giving them to patients. And so the hope there is that we give antibodies that kind of suck up the bad antibodies and help stop the disease. And we've used that in some refractory cases where things haven't worked. Without knowing a little more detail, I think it's hard to know whether it would be helpful. Again, it comes back down to us really trying to understand, when people are flaring or in remission. It's still, a little bit nebulous sometimes.
If you feel this way, is it an opportunity to look for a second opinion with a different doctor?
I feel pretty strongly that if you, as a patient, still have questions you feel like are not answered, addressed, a second opinion is always a great idea. I tell that to my own patients. And as someone who takes care of patients, when I reached a point where I'm not sure what I'm doing, I have the advantage of having, Dr. Falk and our other GN providers and Dr. Orzechowski. I call Dr. Brant sometimes to pick her brain. So I have friends that can turn to second opinions, but if your doctor doesn't necessarily have that availability, then I think a second opinion is more than warranted.
Thanks. And the Vasculitis Foundation just put a webinar up on their YouTube channel about how to politely ask for a second opinion. Since some of us don't feel like we can do that. Next question, what are the statistics of a child not having issues or remaining in remission as they get older?
That is an excellent question. And I would say Dr. Darabell already touched on this, that with rare diseases like vasculitis or other vasculitis, it's really hard to understand all the numbers because of the rarity of the disease. And I would argue that's even more true for pediatrics. So when we think about, we'll take vasculitis as an example, we know it's a rare condition in adults. Well, it's even more rare in children. And so I think, and that's where I feel like there's more opportunity to learn more and get involved in research so that we can know what the long-term outcomes are in children. And we don't really have good information about that. I'll echo something that Dr. Falk already said this morning, which is that, cure is a hard word when it comes to vasculitis. And so we have to think about, I like restoration of health. That's not something I heard before. And I think something that I'll use. And so even when it comes to children with vasculitis, again, we're still focused on restoration of health. And I think the likelihood that they'll need to go on and see doctors like Dr. Orzechowski and Darabell and Brant are pretty high. And it's great that they have multidisciplinary clinics available like this to help care for children. Although I'll put it, plug in that I think you could first in pediatrics. We don't have a fancy website, but I think we did it 5 years ago.
Well, and Dr. Wu is also doing a breakout session at 12:45 about pediatrics, so that might be a great place to go. Okay, this goes back to the last question. You should have just stood up. We would have listened to you. IVIG for low IG levels. Some patients need long-term therapy as every.
Those are different questions, Kevin. So guys, you need to talk about the fact that immunoglobulin can be used. Right. If your rituximab lowers your immunoglobulin level, and there's a very good reason to give pooled IVIG if in fact your immunoglobulin level is low. So I just am worried that whoever asked that question shouldn't feel bad about getting pooled IVIG because you really may need it. So that's why I just wanted to calm whoever asked that question down. We use it for that circumstance. It's a good thing to do. The second thing I'm worried about is I've been watching folks, so I'm just responding to you. The other thing is we have people we can never get off therapy because every time we try, they flare. So that's the other thought that I think you guys need to think about a little. And then I heard an audible gasp. An audible gasp when you guys talked about transplantation and immunosuppression. So I do think you need to talk a little bit more about that. If I can push you guys a little bit. I'm watching and listening to you react, so I'm gently trying to get folks.
So Dr. Wu, you want to kiss that microphone?
Yeah, I'll handle the first one. The other ones I'm not so sure. So like Dr. Falk mentioned, so when I think for the IVIG and rituximab question, again, without knowing the particular details for the case, but Dr. Darabell had mentioned with like rituximab, and as many of you guys have probably had rituximab exposure. So the idea is it's trying to target certain immune cells, your B cells. They're called B cells because they come from your bone or bone marrow. But we think those are, or we know those are the cells that are making the antibodies, the NK things that are causing your condition. But they're important because they also help make healthy immune proteins that we need to help fight infections, right? So these B cells make proteins that tag germs that alert your immune system. You need to get rid of these. And so a byproduct of the rituximab while effectively treating the ANCA vasculitis or other types are that it can cause low immunoglobulins, which are the proteins that the B cells help make. And so the IVIG, like we mentioned, are pooled proteins from healthy donors, these immunoglobulins that your immune system may need to help fight off infections. So, that's part of the monitoring that your provider should be doing. If you're getting rituximab, is not only looking at your B cell numbers, but a potential byproduct of that is what your immunoglobulin levels are doing. And so some of you may need IVIG to help support your immune systems. Not everybody on rituximab needs it, but some individuals do. And so that might be a reason that a person might be on IVIG. Is that sufficient, Dr. Falk?
Since I'm the troublemaker who mentioned the transplant word, let me just start by saying the patient I was referring to, the primary cause of his end-stage renal disease was not his vasculitis. He already had another kidney disease. And then he is at home and he developed horrible pulmonary hemorrhage coming out of his face, pulmonary hemorrhage, and ended up in our ICU. And he was already followed by one of my colleagues. And it just tipped him over to needing dialysis. So let me start by saying that. So what I was referring to is I had another patient who for a short time needed dialysis after his diagnosis, came off for some time, but he had advanced kidney disease. He ultimately got a transplant. I had him on maintenance immunosuppression. I will tell you, nobody's going to transplant someone with active disease and without a stable remission. It's just not going to happen. If they do, it makes me nervous. But I had him on maintenance immunosuppression so he wouldn't flare, so he could get a transplant. He got called in for the transplant, and all of a sudden his, or the first time they did his labs, he was on rituximab. And so it looked like he had a negative cross match. They bring him in for this kidney. And I know this is a lot of words that don't make sense, but, and did have antibodies to this organ. And they were like, what in the world? And then it dawned on the transplant team, oh, it's because he was on rituximab. And sort of masked the fact that he actually ultimately did have antibodies to the organ. So that's that issue. That's sort of its own thing. If someone needs a transplant, people with vasculitis who unfortunately develop end-stage renal disease, which I don't see a ton, fortunately, they can't get transplanted. They don't often flare after they get the transplant because they are then on chronic immunosuppression. It's not actually not the same immunosuppression that we use for the most part, but it still seems to keep things at bay. I hope that answered the scary transplant. Did that answer the scary transplant part, Dr. Falk? Okay.
Okay. Should we go to the next one? Okay. Several people asked this question because it is part of our life, how to deal with insomnia, particularly when you're on prednisone. I know, you all hate it. But we all hate it.
All right. Let's all try. I'm gonna go in a stepwise fashion of how I talk to patients about this. So obviously, step number one is you take your prednisone in the morning. Once in a while, I have patients that say to me, oh, no, I take it at dinner. No, you take it in the morning. Obviously, the insomnia gets better as the steroid dose decreases over time. And then we talk about sleep hygiene, because this is really important. You don't touch your phone or any electronic devices before bedtime, because all of these things, will trigger poor sleep. We talk about having a normal bedtime routine. And then we talk about medications. So there are some things that I'll use in my practice that I think are helpful to patients to help them sleep. I don't like any of the traditional sleep aids. I do like things like gabapentin. If you have, some neuropathic symptoms associated with your vasculitis, we can sort of get a 2-for-1 with that. Sometimes a little muscle relaxer at bedtime is also helpful. Sometimes people prefer natural things, so we'll try, a little melatonin sometimes at bedtime. I don't like to go much beyond that. I don't know if any of you use any of the other sort of sleep medications. I don't like them, but they have a lot of side effects that are not good for patients. Thankfully, most people are not on, very high doses of prednisone for a very long period of time, and so the insomnia tends to be short-lived. That's how I talk to patients.
Thank you for that very clear, very general answer. We try to remind everybody that the doctors can't diagnose you specifically if they're not your doctor, but they're doing a great job answering our quality of life questions. Next one is, I'm someone who only gets a steroid with Truxima infusions. Is there some other form of medication for chronic pain, joints, muscles, not wanting to move? Chronic kidney disease is not related to GPA, or so I've been told. And is there a collaborative clinic available in South Carolina?
Read that again.
Yes. One of the questions is there an amazing clinic like your multidisciplinary center in South Carolina? And no, we don't think so.
I don't know.
I don't know if they have.
I have a friend that travels from Florida to come to this one, so just wanted you to know. She's Louise to my family. So the question was, I'm someone who only gets a steroid with Truxima infusions. Is there some other form of medication for chronic pain, joints, muscles, not wanting to move? And then it says CKD is not related to GPA, or so I've been told.
Okay, I'm gonna take some liberty there and try to maybe interpret what the question is, though I think the question is, what can I use for pain? Not knowing if the pain is inflammatory or not, sounds like maybe this is chronic pain and you cannot take NSAIDs because of chronic kidney disease. We sort of address that with, there are some options that we would use in rheumatology, depending on what the etiology of that pain is. Obviously, we talk about treatment of pain in sort of a stepwise fashion. Again, the safest thing that we use for pain is obviously acetaminophen or Tylenol. Most people have already tried that by the time they get to us. And then depending on really the etiology of the pain, if it's more osteoarthritic pain or sort of generalized musculoskeletal pain, sometimes we'll use duloxetine, that's also known as Cymbalta. FDA approved for the treatment of osteoarthritic pain, fibromyalgia, musculoskeletal pain. We sometimes off-label we use something again like gabapentin or pregabalin for that sort of pain. But if it's more inflammatory type pain, like inflammatory arthritis associated with vasculitis, that's a whole different story, and there are other types of immunosuppressive medications that we can use to treat that.
Great, thank you. Good one. How do we prevent prednisone-related weight gain? I'm giving you all the main ones.
Don't eat too much. No, I'm being semi-silly, but I do tell patients, and I don't use tons and tons of steroids for long-term, but I do tell people, some people don't get the crazy appetite, but some people do. I'll say, you might feel like you want to eat the furniture or your pets. Don't do that. But you do have to be mindful of what you're taking in. You will feel hungry, but if you've had your 1,500, 2,000, whatever appropriate number of calories, you just have to not eat. It sounds terrible, and you're going to be hungry, and I'm sorry. I'm sorry. You're just going to feel hungry. And I just want to touch base. The previous said something about kidney disease not being part of GPA. That is not correct.
Their kidney disease wasn't part of it.
I wasn't clear if they were speaking more generally that they were told that
Maybe that.
CKD was not part of GPA. It just, their kidney disease may not be part of GPA, but in general terms, CKD can be part of GPA. Just to clarify that.
Before we move on from the weight, though, I do want to say, just so people know, that you can do everything right on
Yes.
prednisone and still gain weight.
Yes.
So, we're not gonna, you can eat your 1,500 calories and not eat your cat and still put on 20 pounds. Unfortunately, it's just part of prednisone for many people.
And you will get off that prednisone, I hope. It's not it is something that the doctors all strive really hard to do. So, been there, done that. Is there a really good multidisciplinary vascular clinic near Northwest Georgia? Or like Tennessee, Alabama, or Western North Carolina? They want what you have here.
Emory has a,
Emory
Say.
has one.
out loud, Emory has. Yeah, I'd go to Emory.
And I think Vanderbilt has a nice program too.
That was the next one, Vanderbilt, University of Alabama, Birmingham. Okay. I. One more. Say it.
So as a new patient getting into, I've applied to get into Vanderbilt Vascular Center, but like the appointment's way out, like 6 or 8 months.
7 days.
How do I work the system to get in much sooner?
I can tell you how I did it.
Would you go to the ER
I
or?
did.
No.
No.
Oh, please don't go to an emergency room anywhere in the United States. Please don't go. Emergency rooms are a place of last resort, only if you're incredibly ill. We can chat how to get in.
Great, thank you.
How does that sound?
And if you want to come to New Hampshire, I will not keep you waiting very
There has to be a message of timeliness of care. I mean, if you can't get in to see a doc within 7 days, you're in the wrong spot. And you, I mean, that sounds terrible. But when you folks are sick, you're sick and you need to get seen. And that's got to be part of the equation when you're looking for help.
I would say maybe in general, contact the Vasculitis Foundation and let them steer you towards somebody like Dr. Falk who can help you.
That's what the Vasculitis Foundation is really good at. You know, you need help, they can tell you who can help you nearby.
And another part to that, I think, is if your doctor tries to contact someone there directly to speak to them, that helps a lot. I mean, I think a lot of our referrals we're able to get in quickly because we know a lot of the doctors in our surrounding area and we've had established relationships with them. So they, you know, they call us on our, you know, private cell phones and we'll say, I have this patient, can you help me get them in? And figure it out. And sometimes the paper referral, the urgency of that is lost on paper. And when you have a huge referral system that, you know, people are trying to get through, it's just, the urgency isn't always there.
Thank you. You are amazingly timely. And it is time to move on to our next session. Thank you so much.